Good afternoon, everybody. Thank you for joining the ASTP ONC HTI-2 Proposed Rule Public Health Information Session. My name is Josh Shapiro with Capital Consulting, and I'll be assisting today with the logistical support. If you need technical assistance, please click the chat icon at the bottom of your screen, type your issue into the chat, and myself or somebody else will respond to you to help you with your technical issues. Finally, please be aware that today's session is being recorded. Closed caption is also available by clicking the CC icon at the bottom of the screen. And now I'm going to go ahead and turn it over to Mickey Tripathi at ASTP ONC. Mickey, it's all you.
Okay, great. Thanks, Josh. And hello, everyone. Welcome. I'm really delighted to be here. Mickey Tripathi, Assistant Secretary for Technology Policy and National Coordinator for Health IT. And I'll be very brief. We're really excited today to describe to you the public health components of the HTI-2 proposed rule. Since the beginning of this administration, we have leaned way in from the perspective of ONC to public health. Have worked in very close partnership with CDC and the jurisdictions to use every lever that we can on our side to be able to help us move forward with the kind of public health interoperability that all Americans deserve. And I'm really delighted now to be able to share with you all of the fruits of a tremendous amount of hard work that we, along with our CDC colleagues and our jurisdictional colleagues, have been doing to get us to a place where we can help with the advancement of standards and help through the various certification processes and other kinds of capabilities that we have to be able to move the industry forward. So I'm not going to get off the stage here because there's a lot to cover, and I want to make sure that I leave time for my colleague, Jen Layden, as well. So let me turn it over to Jen now.
Great. Thanks, Mickey, and it's really a delight to be here. And I just want to start off by thanking our ONC colleagues, Mickey, and all the experts at ONC that have worked to make this possible. CDC is fully committed to this vision of modernizing our public health data and technology, and one in which we are as connected to our health IT partners as possible, so that data can be readily available for public health action at all levels, state, local, tribal, territorial, federal level. As many of you know, a year or two ago, one of the recommendations that came out of the advisory committee to the director at CDC was to move forward with public health system standards. That was at a similar time that some work was happening at the high-tech committee with ONC. With those recommendations and the great work that ONC has led, we are now in a position with this rule to really accelerate the work towards lifting up and ensuring the systems across public health meet some basic standards. The work here aligns very much with our the public health data strategy and the goals of which we're trying to achieve, and where we look forward to working with, continue to work with our ONC partners and encourage all public health partners across jurisdictions, across the nation, to work with us to ensure that as we move forward with this, we are hearing from partners, we are hearing from jurisdictions to ensure we optimize this great opportunity. So thank you, ONC, and look forward to the webinar.
All right, thank you so much. My name is Beth Myers. I'm the Deputy Director of the Office of Policy at ONC. I want to thank Mickey and Jen for joining us and for framing the discussion today, and for their leadership throughout this collaborative process. There's been a lot of work that has gone into making these proposals possible. We have several experts from our standards team and our certification team on the call today who will be presenting different aspects of the rule, as will I be supporting the sort of logistical pieces at the beginning here. So I get the disclaimer and public comment guidance, which is our next slide. So for everyone's awareness, the materials in this presentation are based on the content of the proposed rule. And while every effort has been made to ensure the accuracy of our restatement within this presentation, the presentation itself is not a legal document. It is not an official statement of our proposals. Those official proposals are contained in the proposed rule. And for everyone's awareness, if you had joined the overview webinar last week, you may be aware that there were multiple stages to the pathway for publication of this proposed rule. The rule was made available on ONC's website, and then middle of last week, it was put on display by the Federal Register. So that means there is a PDF display version available on the Federal Register, as well as their schedule for that publication. The publication that they have scheduled will be August 5th. And when that publication occurs on August 5th, the comment period will become open. And that is when the Federal Register system will open for public comment, and you can begin submitting public comments. The comment period is 60 days. 60 days takes us to October 4th for the close of the comment period. I will be double checking that and posting it when the actual publication happens. But our understanding is that that's what the comment period would be. That is what the OFR has determined. To clarify for everyone on why these things matter and the difference between the display and publication and the open comment period, ONC must protect the rulemaking process, and so we cannot be opining or taking detail level questions on our intent. We have to stick to what is in the proposed rule. In addition, we cannot accept any comments coming in by anyone attending through any informal means. All comments must be submitted to the Federal Register and must be submitted via the comment submission process on the Federal Register. So all of that information will be made available. We are keeping an eye on the Federal Register to make sure that those dates are set and that they meet those dates, and we will continue to provide that information out to the public as soon as those dates are set and the comment period is open. So let's get started on the actual topics at hand. If we can go to the next slide. So for today, I'm going to very, very briefly touch upon the overarching purpose of the HTI proposed rule, and then we'll be going to a short overview of the certification program from a historical point of view that will help to lead into the conversation that we're having today, where we're laying out all of our new and revised public health data exchange certification criteria. There is quite a lot of substance in this presentation. I do remind everyone that, as mentioned, we will do our best to cover the detail, but you are going to want to read the actual rule to see the nitty-gritty details. I hope that you find it useful and helpful as you are reading, as we work very hard with our partners to try and make it as clear as possible. And do provide comments back to us on what you think of the proposals, what you think of the questions that we've provided. Next slide. So very briefly, an overview of the purpose of this rule. The public health section is one aspect to it. Overall, we've sought to continue to advance our work that was under the 21st Century Cures Act. So we finished the 21st Century Cures Act final rule, and that was previously published. Many of the aspects within that were further advanced in the HTI-1 final rule, which was finalized in January and effective after that date. That rule put forward several pieces that are relevant for the conversation we're having today, including updating some of our public health standards, looking at FHIR-based exchange for some limited public health use cases, and trying to set a reasonable standard for how that data will move and what the timelines for advancement between versions of the US CDI should be. So what we're trying to do with this proposed rule is to continue to expand on that and to identify additional areas that are part of ONC's scope and ONC's authority where our collaborative work can advance additional technical capabilities, advance aligned standards, and ensure that we are continuing to create a nationwide health IT infrastructure that is interoperable for the entirety of the healthcare system. So that includes doing things like ensuring that we have covered the information blocking provisions, the policy changes within that, our work to continue to advance TEFCA, our work that fits in accordance with the administration's goals defined by executive orders, including to focus on public health, advance real-world equity, and promote areas where the federal government can be a force for change that is looking at customer service, patient experience, and building a sort of trust-centered government that is focusing on advancing the individual's needs. And then also looking at our authorities across the HITECH Act and the 21st Century Cures Act to really advance interoperability in key areas that may have been either left behind by prior engagements or prior policies or prior programs, or where readiness needed to get a little further along so that we could start to make those changes. As Mickey and Jen mentioned, we've come to a point where those are those readiness factors and those important exchange purposes have the ability now to begin moving in these directions and aligning and becoming part of the overall infrastructure. So our goal is to try and ensure that that can happen in a way that creates and supports interoperability and really builds an infrastructure that can be leveraged by multiple entities across the healthcare system. Next slide, please. So with this, I'm going to pass it to my colleague, Jeff Smith, who is the Deputy Director of our Certification and Testing Program. He'll do an overview of the program. And then Jeff will be passing to Molly Pretto, who is our Deputy Director in our Standards Division, who will be going through the individual criteria. You'll hear from me again later on, but I want to pass it off to Jeff now, and we'll roll into the actual content of the rule.
All right, thanks, Beth. Okay, because we are talking, or we'll be talking about a series of proposals that may impact a new set of developers and actors, we thought it would be good to just spend a couple minutes talking about kind of ONC and the certification program as a whole before moving into the specific proposals. So I think it's fairly important to underscore that the certification program is a piece of a larger set of activities. We obviously adopt standards on behalf of the Secretary in addition to certification criteria, but we also, through various certification criteria and through the Trusted Exchange Framework and Common Agreement, very much focus on exchange activities. And as demonstration of what was discussed by Jen and Mickey earlier, we do a lot of coordination both with federal partners as well as state partners and the broader public. And a lot of what we are going to talk about here today, in addition to the goals and objectives that Beth just outlined, are primarily targeted at advancing the development and use of health IT capabilities, as well as establishing expectations for data sharing. So I think one of the really important things for this audience is to try and remember what the landscape for clinical IT looked like back in 2008 or 2009. The market was really characterized by low industry adoption of EHRs, different or no standards used to capture clinical information, a lot of uncertainty about how a product would perform in clinical settings, as well as information silos that hinder information sharing and interoperability. And I think as we sat to look at the landscape for data exchange between healthcare settings and public health entities, we noticed some similarities. If we look at the example in the clinical care space, you can go to the next slide now, please. We can talk pretty, I would think, enthusiastically about more than 10 years on, we have more than 400 health IT products that are used by 96% of hospitals and nearly 80% of clinical offices, and are referenced by numerous federal programs. And I think a lot of this is, this didn't happen by accident. We have endeavored over the last several years to really be solutions-based and, standards-based and solutions agnostic. Everything that we do in the program, generally speaking, relies on technical implementation specifications and technical standards that have gone through kind of ISO and ANSI accredited standards development processes. And we're looking to do a lot of the same as it relates to both existing and proposed new certification criteria for public health IT. I think the other thing to hammer home at this point is that the program certifies health IT software and includes requirements for certified software developers. The program does not include requirements for the adoption and use of certified software. So that means that we regulate software and the developers of those software. We don't regulate the users of those software. We work with partner agencies like CMS to ensure that the adoption and use of certified software and associated programs and requirements are coordinated and aligned. And that's how we achieve this kind of coordinated approach between the certification of software and the actual use. So as we go through these proposed certification criteria and these proposed updates, please keep in mind that what we're talking about specifically are certified software and the developers of certified software, not necessarily the users of the software. Okay, next slide, I think. Okay, I'm going to go ahead and hand it off to Molly, and so Molly, take it away.
Thank you so much. Hi, everyone. Great to be here. My name is Molly Proto. I'm the Deputy Director of the Standards Division at ONC, and I will be bringing us through the details of the revisions and new Public Health Data Exchange certification criteria. We can move to the next slide. Thank you. As Jeff mentioned, there have been components regarding Public Health Data Exchange in the certification program for quite some time. And so it's many of those particular criteria we've revised or proposed to revise in this updated rule. For those who have been familiar with the certification program, F1 through F7 likely look quite familiar to you. And I will talk us through each one of those in more detail on later slides. But for now, as a high level overview, throughout those current criterion, we propose revisions to those particular elements by updating standards. And as Jeff mentioned, we really aim to be standards based and solutions agnostic in our certification program. And so we proposed to revise to the most updated version of those standards. You can see in F1 through F7, we propose to update to the most recent versions of those existing standards, whether those are CDA or other V2 HL7 standards. In addition to those standards-based updates, we also propose some additional functions that we will get into on later slides in each of those criteria. While we're on this slide as well, we also propose 2 new criterion that would address the transmission of information to public health agencies. You can see there on birth reporting, which is F8, and prescription drug monitoring program, which is F9. We propose those net new criteria. In birth reporting, we do point to the HL7 FHIR implementation guide as a standard there. And in the PDMP criteria, as Beth will talk through in a later slide, that is a functional requirement that does not include a particular standard. You can move to the next slide. So on this slide, we see all new criteria. For those who are familiar with the certification program, 20 is probably a new number to be seeing in the Fs for all of you. So these are all new criteria that we propose within this rule to be accompanying to those criteria on the prior slide. As you will see here within the details, we included the same standards version within each of the corresponding criteria. So F21, which is for immunizations, receiving, validating, parsing, and filtering immunization information, is pointing to that same HL7 implementation guide that we included in F1. And again, we'll get into each of these details on later slides, but wanted to just make the point that throughout all of these corresponding criteria from F1 to F21, F2 to F22, that the intent is to mirror those standards to ensure that the sending and the receiving systems are meeting those same standards and have corresponding functions. In addition to those corresponding functions, you will also see here we included cancer pathology reporting in F24, which I'm excited to explain on a later slide. And that one is also pointing to an HL7 FHIR cancer pathology data sharing implementation guide. So with that, let's jump into the details. We can get into the next slide, and I think we can skip right into the next one there. We've got all the headers there. So for immunization information, there are 2 primary proposals that are relevant to the transmission and receipt of immunization information. So F1, which is the current criteria that has been in the program for some time, we made some revision or proposed to make some revisions, as I mentioned earlier. You can see here that we updated to the most recent version of the HL7 version 2 implementation guide. We also updated to the most recent vocabulary standards for the code sets that are relevant for immunization information. We also, in all of the F1s, made some minor name updates that we don't need to spend time on each of those. But in addition to those vocabulary and standards updates, we also included an additional function, which is the receipt of incoming patient level immunization specific query or requests from external systems. And that is a functional component within that criteria. In addition, for immunization information, as I mentioned on the prior slide, we also created F21. And F21 is the receipt of that information that ideally would be sent in F1. So the complete name for this is immunization information receive, validate, parse, filter, and exchange response. So that would include, again, as I mentioned above, that same HL7 version 2 implementation guide that's included in F1. And it also includes the same corresponding function that we proposed to introduce above, which is the response to incoming patient level queries from external systems. Again, what the intent here and throughout the rest of these slides is that we have those corresponding requirements that mirror the same intent. So what one system is sending, the other system is able to receive and validate, parse, and filter. Apologies, I am doing my best to speak slowly, which I am generally not great at. So I appreciate folks' patience if I stumble a bit. And so with those corresponding functions, we're making sure that we are pointing to the same standard and the same functions to allow for that kind of aligned maintenance and aligned adoption. Next slide, please. And again, so for syndromic surveillance, there are two primary proposals here as well. One is in F2 and one is F22, that corresponding one. Within F2, it was a standards update within the NPRN. We updated to the most recent version of the HL7 version 2 implementation guide, that minor name update that I mentioned earlier. And then correspondingly on F22, we established a new certification criteria that would mirror that same receipt function that immunization information does. So syndromic surveillance, receive, validate, parse, and filter. And that would enable a user to receive, validate, parse, and filter electronic syndrome-based public health surveillance information according to that HL7 2.5.1 syndromic implementation guide. So again, really working to make sure that those criteria are aligned and using and pointing to that same implementation guide. So the standards are updating in advance or in tandem, apologies. We can move on to the next slide and dig into laboratory orders and results. So instead of two primary proposals for laboratory orders and results, we get three for this one. So this one is a little bit more complicated than some of the others, given just the complexity of laboratory interoperability. So there are a few different components that we can talk through here. One is that we did update the existing certification criteria at F3. And so in addition to updating the laboratory implementation guide to the LRI implementation guide, so that's the laboratory results interface, apologies, implementation guide for the transmission of reportable laboratory results. We also included the ability to receive and validate laboratory orders, and that would be according to the laboratory orders interface implementation guide. And so within F3, there was both that update to an existing implementation guide for the transmission of reportable laboratory results. There was an additional function added for the ability to receive and validate laboratory orders, and that is according to that LOI implementation guide. That's all in F3. Additionally, we get a new letter here. For those who are familiar with the program in A2, we also made updates, proposed to make updates to the computerized provider order entry laboratory certification criteria at A2. And within A2, we proposed the ability to create and transmit laboratory orders using that same implementation guide referenced above, the LOI implementation guide, as well as the function to receive laboratory results according to the laboratory results interface implementation guide. So you'll see here again that mirroring where we're working on ensuring that the components within the certification program include transmission as well as receipt, and that those transmission and receipt criteria are both pointing to the same implementation guide. The third criteria that we see here for laboratory orders and results is F23. So back to our original pattern here, which is reportable laboratory test values and results. Receive, validate, parse, and filter. And so this is that corresponding ability, adhering to the LRI implementation guide to be able to receive, validate, parse, and filter those reportable laboratory results. So I know this one, again, has 3 components and is a bit more complex than some of the others given the role of A2. So as folks are looking at our very readable rule, you make sure that you also look at A2 when you are thinking about laboratory interoperability, in addition to F3 and F23. We can move to the next slide. Oh, thank you. I did get into this on the prior slide, but this is a deeper dive into the CPOE requirement again at A2, just given that this is not necessarily within the F criteria, just some additional information on what we did to update the A2 criteria within the proposed rule. Next slide, please. Cancer registry reporting has been an F4 criteria for some time, so we can get into the next slide. You'll see here that similarly, I'm sure you're getting used to this pattern. We proposed to update to the most recent version of the HL7 implementation guide. This is an HL7 CDA implementation guide for reporting to public health cancer registries. In this particular rule, we also proposed the ability to use either that HL7 CDA implementation guide or the Cancer FHIR implementation guide. And so this would allow programs that are, this would allow vendors and developers who are going through the certification program certified to either the CDA implementation guide or the FHIR implementation guide. In addition to that standards update within cancer registry reporting, we also included a new function according to a new implementation guide. That new function is cancer pathology reporting transmission, and that is according to the HL7 FHIR cancer pathology data sharing implementation guide. Correspondingly, in F24 is only looking at the receipt of that new function I mentioned. So F24 is explicitly looking at cancer pathology reporting and the receipt, validation, parsing, and filtering of that information. Again, that would be enabling a user to receive, validate, parse, and filter cancer pathology information according to that same HL7 FHIR cancer pathology data sharing implementation guide. Next slide, please. Electronic case reporting. So in ASTP's earlier rule this year in HTI-1, we did finalize an updated requirement for electronic case reporting that many of you may be familiar with. We are proposing an update to electronic case reporting, which is F5, to point to the HL7 FHIR ECR implementation guide. And so today that HTI-1 requirement allows either the use of the CDA ECR implementation guide or the FHIR implementation guide. This proposal in HTI-2 is proposing that the only standard that the certification program would point to is that HL7 FHIR implementation guide. Correspondingly, at F25, we additionally proposed to establish a new certification criterion for electronic case reporting and receiving, validating, parsing, and filtering electronic initial case reports. And that would be, again, according to that HL7 ECR FHIR implementation guide. Each of these components, F5 and F25, also include include components that point to the reportability response. And apologies that that's not in the F5 detail on the slide here, but you can see in F25 that we also include that create and transmit reportability responsibility, and that would be according to that HL7 FHIR implementation guide. Next slide, please. In antimicrobial use and resistance reporting, that is not one I recommend saying 10 times fast, which is F6. Apologies for that mistake in the slide there. This is an F6. We would update the current implementation guide to the most recent version. In this particular measure, so for F6, we do not have a proposed corresponding 20 criteria. So there is only one relevant proposal for antimicrobial use and resistance reporting. And again, that is to update the current implementation guide that you see to the HL7 CDA implementation guide here. Next slide. So for healthcare surveys, similarly to antimicrobial use and resistance reporting, there is one primary proposal that is relevant to healthcare surveys. We propose to update the current F7 criteria, but we do not have a corresponding criteria in the 20s here. So we propose to update the F7 criteria to support the most recent version of the HL7 CDA implementation guide for healthcare surveys. We additionally included a request for comment on the use of the FHIR-based healthcare surveys content implementation guide. And so look forward to receiving additional comment on the use and adoption of the FHIR-based healthcare surveys implementation guide, and if it is ready to be included within the program. Next slide, please. So birth reporting, as I mentioned early on the overview slide, is completely new to the program, both at F8 and at F28. So we proposed both the transmission to public health agencies as well as the receiving, validation, parsing, and filtering of birth reports. And each of those criteria at F8 and at F28 are pointing to that same HL7 FHIR Vital Records implementation guide. And I believe that with the next slide, we get into the details of the prescription drug monitoring program components, and I will pass back to Beth.
Sure, thank you, Molly. So for those of you who have been following for the past, at least 6 years since the Support Act was enacted, there has been a lot of work by HHS to try and support the advancement of prescription drug monitoring programs in a way that actually supports both OUD treatment and prevention, as well as the potential needs of clinicians in clinical settings to identify risk for their patients. So there has been work by CMS that includes measures for electronic prescribing of controlled substances to query a PDMP. There has been work by CDC and by the Department of Justice to advance PDMP use that can expand the user sets across the country so that it isn't a drug enforcement tool, but instead is a clinical care tool. And CDC has put out a wide range of guidelines that actually relate to best practices for prescribing controlled substances and for monitoring prescription drugs that include different points of clinical care and different points of measurement of risk at different intersections throughout a clinical process, whether that is at the point of electronic prescribing or at the point of doing a medication reconciliation or other points of care along the care continuum, especially for individuals who may be at risk for substance abuse. So what we've determined to do with this criterion is to try and create a tool within a certified health IT module that can support the various parts of that process and that transaction, recognizing that there is not yet a fully completed, agreed upon standard that encapsulates the entirety of the transaction. There are several standards that exist for different parts of it, that exist for different pieces of the transaction, but there isn't necessarily a criterion in a certified health IT module that captures the actions that are part of what might be referred to in like a CMS program as a qualified PDMP, or the integration of that particular information. So we have put in 2 criteria to allow certification to the processes that we know are prevalent in the industry for prescription drug monitoring programs. And we've also highlighted within those proposals areas where we think there is standards advancement underway, including FHIR-based standards. We have one criterion that allows for a system that would be on the clinician end, on the clinical side, for a clinical user that is an authorized user, and there are different access rules established according to commonalities across state law. So we identified the most common access rules across state law and made those a minimum, and that it required that developers should work with healthcare providers to identify appropriate additional roles within their state, and defines that they need to be able to query, receive, validate, parse, and filter data from a prescription drug monitoring program, including an interstate hub. So that would include an interstate query. To be very clear, we also incorporated a receive, validate, parse, and filter prescription data and supporting a query of that system. And we envision these being used in several different ways. The prescription drug monitoring trigger might happen at many different points of care and might happen in many different settings, or among different types of payment systems while doing billing or reconciliation or referral. So we tried to make them agnostic to the specific user and instead focus on the reciprocal transaction of querying a PDMP and receiving information from a PDMP. We also, very importantly, noted that at a minimum, that data needs to be, transmitted back from the PDMP to the querying system, needs to be in a computable format. And we use the USCDI data standards as the baseline for that, so that it is a structured data construct. And this is essential to being able to actually integrate PDMP data back into a record system, whether that's a patient record or a patient care plan that might be shared across providers. It's essential and important to be able to reconcile the information within the medication list and ensure that any prescription drug monitoring data is actually being received as discrete data, not as a view-only report or a view-only risk score, but as discrete data that can be incorporated to the record or reconciled with the record. So that's our proposal for these 2 particular criteria. They're a little bit different than some of the others, as mentioned, because the entirety of these criteria is functional. Again, we recognize that there are standards out there under development. There are standards out there in current use. What we are hoping to sort of look toward and continue to evolve are potential standards that might encapsulate the entirety of the transaction as open standards that are based on consensus and can be leveraged by lots of different types of systems. So with that, I think I am handing off to Jeff.
That's right. Thanks, Beth. All right, so I'm going to bring us home on a criterion that you'll notice doesn't include any of the F criteria as we've been talking. So I think what you've been hearing from both Molly and Beth is a little bit of a call and response in terms of the certification criteria that we are proposing for users who are generally going to be of clinical health IT systems. And then also in our proposals, we did call out this notion of health IT for public health. And, you know, I think as we look at both the single kind of F single digit criteria, F1 through 9, and then corresponding certification criteria, F 20 through 29, we're trying to think in a coordinated fashion about certification criteria that would essentially be able to send and receive information according to specific standards. And so as we look at this last kind of piece of the puzzle today, this is a certification criterion that builds on a rich history of our standardized API for patient and population services at G10. So if you go to the next slide, please. So our proposal here is actually to establish a standardized API for public health data exchange. And we think that this would extend the capabilities that are already included in the certification program in the standardized API for patient and population level services. And it would support ongoing and future development of public health FHIR IGs leveraging a core set of existing modular and extensible capabilities and standards. And I'll back up for a moment and just underscore that that is the FHIR implementation guides. We really do think that this proposal is a necessary first step towards furthering a FHIR-based ecosystem that would support a wide array of public health data exchange use cases. We also believe that this proposal would streamline and reduce reporting burden for healthcare organizations and developers while expanding public health authorities' access to and critical use of data for public health purposes. We also think that this proposal would extend the capabilities included in the standardized API for patient and population level services at 45 CFR 170.315 G10 by requiring support for FHIR resources profiled according to the U.S. Public Health Profiles Library Implementation Guide, or the US PHPL-IG for short. We believe that this proposal would ensure that PHAs have consistent access to discrete functionalities, defined capabilities, and standardized data from providers using certified health IT systems for a range of public health use cases, as well as support ongoing and future development of public health related FHIR implementation guides that leverage a core set of existing modular and extensible capabilities and standards. Next slide, please. Okay, so focusing just real quick on the US PHPL-IG, we did propose that modules who are certified to G20 focus on being able to read and search and handle more or less the US PHPL-IG data elements. And really our intention here is to leverage a public health specific data set of common data elements that are necessary to support core public health exchange use cases. This IG contains reusable content profiles that represent common data elements that public health officials need to receive and use. And we note that it's created as a complement to the US core implementation guide, and that it reuses US core profiles whenever possible. And we note that it only adds new profiles when there is a need for specific profiles for public health data exchange, and there's no corresponding profile in the US core IG. We believe that the US PHPL-IG would enable the exchange of health data from healthcare organizations to public health agencies with minimal implementation burden due to its foundation in the US core IG and its alignment with G10, and through the reuse of common profiles for public health data exchange purposes. And we also note in the proposed rule that we will support updates or intend to support updates to the US Public Health Profiles Library IG and align with US CDI plus public health. Next slide, please. Okay, so to try and give you somewhat of a visual demonstration of what we're requiring here in G20 is, as you can see here on the left, we've got a provider system that would be a certified system used by a clinician. And we are proposing that these systems could be certified to G20. They would be using a lot of the same registration and authorization functionalities and have those capabilities that currently exist in G10, with the noted addition of dynamic registration, authentication, and authorization. We do propose dynamic registration as a part of other aspects of HTI-2. And essentially what that would allow is more facile connections between apps, both kind of user apps as well as system apps, without having to go through a kind of more manual registration process and authentication process. You can see here in terms of the content, we are proposing that G20 modules support read and search capabilities of profiles according to, again, the US Public Health Profile Library IG, not the US Core Implementation IG, although we do ask questions about whether one implementation guide is better than the other. And then notably, we are proposing that subscriptions are used as part of the G20 certification criteria. And I think it's really important here to note that subscriptions is part of what we're calling API workflow capabilities. And essentially, subscriptions allows for a much more dynamic exchange environment. It allows different systems to get different information based off notifications and based off subscriptions to updates to data elements. And again, this is part of why FHIR is such an interesting and important path forward, because rather than getting a document every time a data element changes, under new reporting paradigms and new data exchange paradigms, different parties are able to get just the updated information or get information that is related to just the updated piece of information. So we have a number of really, I think, important proposals and are trying to move this really kind of fundamental capability of FHIR forward through the subscriptions implementation guide that we've proposed. And then we also proposed the use of version 2 of the bulk data access implementation guide, which we think will enable better access to bulk data. So, again, I mentioned this kind of call and response that we've gone through previous slides and with the F criteria. I think here's kind of a differentiator. The G20 certification criteria would be primarily focused again for adoption by providers and for certification by the IT developers that they rely on. And really what we're trying to do is we're trying to set the landscape for the development and refinement of public health FHIR implementation guides. We know, and we just walked through a whole series of different standards that we're proposing, and many of those standards, not all of them, but many of them are CDA based, and a couple of them are FHIR based. And we think that if we can kind of prime modules that are used by developers to be able to exchange information for public health use cases through G20, we can support the development and growth and refinement of a whole bunch of different implementation guides on the public health side. And we've listed some of those here today, but I think it's also important to note that FHIR represents a new paradigm for public health reporting. It reports a new paradigm for public health and clinical care information exchange. And so while we were proposing kind of corresponding implementation or corresponding certification criteria for immunizations and for lab reporting and for case reporting, we don't have a corresponding certification criterion for G20. What we're hoping is that that G20 will provide a pathway through which new exchange paradigms can grow, and that depends on development of implementation guides on the public health side for these and other use cases. All right, so with that, I believe that's the last slide I've got before handing it back over to Beth.
Yes, thank you. So I'm going to talk a little bit about the resources we have available and a reminder for the public comment period. But I did want to address that, again, we aren't taking Q&A on these overview webinars for the proposed rules. However, there were several cues that I saw that we did state several times, but I'm going to restate a couple key pieces because I think they're relevant for everyone's understanding as you are reading this part of the proposed rule, but also the part that we're going to be talking about at our session coming up, which is the patient, provider, and payer API. For ONC's certification program and ONC's certification criteria, what we are talking about when we talk about them in our rules, in ONC ASTP rules, is the functionality and standards that technology is required to meet in order to be certified under our program. That technology is a really important thing to remember there. The developer of that technology is then held accountable to certain maintenance of certification requirements, conditions of certification requirements that relate to transparency, that relate to not having gag clauses on communications, that relate to certain things for fees for certain use cases, and that are essentially providing assurances that the technology will function in an interoperable manner as it was intended to do via the testing process. So the other piece that goes along with that is a condition and maintenance of certification requirement on the health IT developer is things like real-world testing, the information blocking conditions. All of those apply to the developer of technology, but the first step to be considered a developer of technology is that is the entity who has a technology health IT module that is being submitted to the program for certification of the technology. It's a really, really important point. ONC programs are agnostic to the user of the technology. And I realize that that always sounds weird when we say things like that, because we know that there are very significant trends in who uses ONC certified technology and who may not do so yet. But the point is that those types of requirements, for example, the affectionately called meaningful use requirements, promoting interoperability requirements, are established by CMS. So CMS is the entity that is determining that a eligible hospital in the promoting interoperability program is required to use certified technology for certain actions. So what ONC is defining is what does the technology need to be able to do, regardless of whether it's a hospital using it, an HIE using it on behalf of a health system, an ACO, which is organized of some parts of several different types of health systems and care providers and settings, or any other entity that might need that functionality to work in a way that is consistent and clear with the standards and functionalities defined. So when we talk about public health and we talk about the F criteria and the paired 20 criteria, so for example, immunization registries, so F1 and F21, what those are doing is trying to look at the whole of an interchange, and bidirectional exchange, which could even be multi-directional exchange. So what are the things that need to happen that allow for that exchange of that information, no matter who is doing a query of a immunization system or who is transmitting immunization system to report that an immunization was provided, or to report back on an immunization report that is showing how many immunizations for a particular child have been covered and have not. All of the users of that space would be somewhat agnostic. Now, we know there are common users that would benefit from having this technology available to them, and we tried to take into account what their individual needs might be, but we also are trying to set the stage for a broader understanding of what it means to have certified technology creating infrastructure. So we're thinking about things like entities that might be in a third-party role that are supporting that ACO, entities that might be supporting immunization services in a way that is allowing for parents to easily track all of their children across an immunization platform, which we know some immunization registries have been interested in trying to explore through things like an IV gateway. So each of these sort of advancing concepts becomes more and more readily available as we continue to advance modern technologies like standards-based APIs, as we continue to advance other parts of our work like TESCA. So what we're trying to make sure is that as we're evolving our criteria, both the F criteria themselves, the original ones that were for sending the data, but also receiving and parsing, those could be used by lots of different types of entities. For example, an entity that is serving to aggregate data from multiple points, like an HIE, might need to have an F criteria to be able to send it according to the standard. So we're trying to accommodate that and be as agnostic to the individual user as possible, keeping in mind that it's the technology itself that is being certified and the entity that is the developer of that technology that is subject to the conditions of certification. So it's just an important way of understanding these things that I wanted to make sure we were being very, very clear about it, because it's incredibly important for public health from our point of view to be building for a future state while also trying to make sure that we're accommodating the current state, the gaps that there are in completing transactional interchanges for bidirectional public health data exchange. So I'm going to stop going on that particular part and do what I was supposed to be doing, which is the resources available. We have fact sheets on different sections of the rule that are available at healthit.gov/proposed rule. We have also linked in the display version of the rule on that page. So you can now find that there as soon as the Federal Register has officially published and opens the comment platform. We will be linking that in on that page as well. You can also find the recording from our overview webinar on that page, and the recording from this webinar will be on that page as well. And if we can go to the next slide. The instructions for submitting a comment, again, this is not open until the Federal Register has published and opened the public comment period. But if you want to write it down, the RIN number there is a really easy way to search for it. You can also just look for rules that are done by HHS. You can also look on our website, because it's noted we will be updating it with the correct link to the published version. And then on the Federal Register itself, on regulations.gov, you can submit your comment through the process. And that is the formal process. That's actually how we need to receive your comments in order to consider them as we're approaching our decision making around final policies for the final rule. So with that, I will close us out and thank everyone for coming, and thank you to Mickey and Jen for coming in and framing our discussion and sharing your leadership and thoughtfulness about how we're getting where we're going together. And then to Molly and Jeff as well for their support presenting, and then our support team as well. Thank you for everything. And for all those of you who participated, thank you so much for joining us, and please keep an eye out for our next session.